Good evening. Pharmacology for the EMT. We're going to look at two real different types of medications that you will be involved with as an EMT. What you need to understand as you go and visit patients and treat patients and look into their lives and what's going on with them, you're going to hear about many, many different medications. There is no time in EMT school for me to teach or even touch on all the different types of medications that your patients will already be taking. What tonight's lecture is to do is to talk about the limited but ever-growing list of medications that you as EMTs in New York State are either permitted to carry and give to a patient or to assist the patient with their own medication. Very often you'll come to a call and the first thing the family member will say, oh, they missed their medications this morning, should I give it to them now? All right? The answer is 9 times out of 10, no. Okay? There are very specific medications that the patient has that you are allowed to assist them with, and we will go into those. And then there is the group of medications that you and every EMT in the state will be carrying in your kit, in your bag. Yeah.
What about them taking it themselves?
Again, when you arrive on scene, it starts a new chapter. Okay, and that started from your arrival time. You don't want them taking medications. Number one, you're not proficient in what these medications are, how they work, what they do, or whether it's good or bad for the acute distress that they are now in. That's not for you to make that decision or to decide. Okay? There are, however, a couple of exceptions to that rule that you will assist the patient in taking medication. And there are then the medications that you yourself as an EMT will be carrying in your kit. So here we go. We'll start off with some words that are connected to the topic. Pharmacodynamics is how a medication works, how it acts on the body. Okay? Agonist, and then the opposite is antagonist. Okay? An agonist causes something to happen or to happen more. So if I say this is a sympathetic agonist, what's it doing?
Affecting
the sympathetic nervous system, right, and stimulating the receptors of the sympathetic nervous system. So a sympathetic agonist will do what? In simple. What does the sympathetic nervous system do?
Sympathetic is
when it's fight or flight.
Fight or flight, right? Speeds things up. Very good. The opposite is a antagonist. Antagonist blocks those receptors. So a sympathetic antagonist would do what? Slow things down. So think now. A parasympathetic agonist
equals a sympathetic
would be similar to a sympathetic antagonist. And this is really how drugs work. A lot of the drugs, we're not going to go into it in major detail, but just so you understand, drugs commonly do one of these 4 things. Okay, either they're an agonist for the sympathetic or the parasympathetic, or they're antagonist for the sympathetic parasympathetic. That's how a lot of drugs, legal and otherwise, how they actually work. Dose is the amount of drug you give, and the action is how it works, what it does. Indications and contraindications. I hope that these 2 words are common words for you now at this part of the class. I'll just run through it again really quickly. Indication is the reason to do something. Here we're talking about take a medication. If we're talking about using a traction splint or using some other piece of machinery, equipment, mass pants, doesn't matter. An indication is reason to use it. The opposite will always be a contraindication, which is even if the indications are met, there is some other outside reason why we shouldn't use it. Okay, and we saw this with traction splint, we saw this with mass pens. Now, same thing with medications. Let's just talk quickly about the different names of medications, because this is interesting, not necessarily you'll be tested on, but very interesting just for you as EMTs. Every medication has at least 2 names, actually 3, but we just mentioned here 2. There is a generic name, and there is a trade name. So let's take the simplest, most common medication probably in the United States, and that is Tylenol. Probably the simplest, most common known medication in the entire country. Tylenol. What name is that? What is the name Tylenol?
Brand name.
Okay, Tylenol is a trade name. That name is owned by a company, and that is a trade name. You cannot decide to start producing pills tomorrow and call one of your pills Tylenol. You're not allowed, because the name Tylenol belongs to the company that owns that name. It's a trade name. However, there is a generic name.
Somebody's sitting there like dying on the floor, you know?
Trade name Tylenol, generic name acetaminophen. Right? Now this goes for every single drug in the world. And it's very interesting, because if you go to the Rite Aid and you buy a little thing of Tylenol, it's got like 10 capsules in it, right? Cost you like $8, okay? You go to Costco or one of the big stores, Walmart, and you buy acetaminophen, you get like 800 pills, okay, for $3.99, all right? It's the same thing. It's the same thing. It works for all the drugs. It's all the same. Motrin, Advil is all
You walk into CVS.
ibuprofen.
They
So
put
you
on the thing.
Would you ever buy brand name?
Generic.
No,
No?
You don't buy brand new?
no, absolutely not.
So the name is, that's the generic name, that's a prescription name by the Costco now.
There's nothing to do with prescription.
Oh, okay.
We're talking about over-the-counter drugs. Prescription drugs have the
Generic.
same thing. Okay, many times you'll see a patient taking a drug that you've never heard of, never seen before. Then you find out that it's a generic name for something that you have heard before. Okay, so this is what happens all the time.
Isn't
Just-
just be oxygen a medication?
What?
Isn't oxygen?
It is.
So
It
there's
is.
only one name for oxygen.
Pretty much. Prescription and OTC. We refer to certain drugs as OTC, over the counter. These are just things like your Tylenol and Advil, etc. A good one to know is that children's Benadryl. Good one to know. For example, children's Benadryl, if you buy the Benadryl brand, will be extremely expensive. But if you go to a place like Walmart or Costco, somewhere that makes it, it's called diphenhydramine. And it's exactly the same thing, same strength, same potency, and does the same job.
Oh, that's a good question. My friend knows, one of the friends in the class, what's the, for Viagra?
He's asking for a friend. He's asking for a friend now.
Someone wanted a cheaper route. No one knows. What would be
No,
the cheaper
no,
route?
it's not Cialis.
What would be the over-the-counter,
Can I answer you after class?
I'll tell my friend.
I'll actually talk about that drug a little bit if you want to know soon, okay? I'll explain to you about it.
Is there a biochemistry name or a
Yeah,
chemistry name
there's
for
a
the drug as
chemical
well?
name for every drug. That's the third name that I didn't really speak about, okay? Yes, there's a chemical name.
That's just the chemical makeup of the drug.
Yeah.
And that's different than the generic.
Yeah.
It's like 900 syllables long,
Yeah,
and there's
yeah.
a whole bunch of Latin words in
Yes.
it.
Is that what
Sildenafil.
NSAID is for Motrin?
Sorry?
NSAID.
No, that is a group of drugs, Motrin being one of them. But that has nothing to do with a chemical
Usually in
name.
parentheses under it, and it's like that long.
Yeah. Okay? Alright. Let's keep going. Medications come in different forms, solids, liquids, and gases. We'll talk about that as we move on. I wouldn't get too into it as to which ones are which at this time. Alright, very important words. Enteral and parenteral. Okay? Enteral means that the drug gets into the body through the digestive tract. Okay? There are typically 2 ways to get into this tract. Alright? Either From the top down or from the bottom up? Literally, okay? So these are the two ways that we use parenteral drugs. All the other methods are called parenteral. Now I have a star next to some of them. I want to point out what that means. If there is a star, it means that an EMT is allowed to use that method of delivering a drug. Okay? So, oral, PO. You should know these terms now. Oral, we call it PO. A drug was given, how was it given? PO. Means in the mouth, and this has a star. The other one an EMT is allowed to do is sublingual. Easy word, sub means under. Lingual is the tongue, as in language. Right? Sublingual, under the tongue. An ENT is allowed to do that also. We'll get to the specifics later. IV and IO, you're not allowed to do. Inhalation.
Inhaler.
Okay, inhaler, breathing something in, oxygen, right? It's given through inhalation. Good. Intranasal, that is sort of new in the last 20 or so months. That's up into the nose, the mucosal membranes of the nose. We'll talk about that. Intramuscular is a shot that goes into a muscle,
EpiPen.
all right, such as an EpiPen. Sub-Q and transdermal, there is no EMT, no indications for EMTs to do those. So,
What are
those? What are the example? Like an ointment, a topical ointment?
what transdermal means through the skin. You will not
So
be doing
Like
that.
an ointment?
Yep, anything
And
through the
what's the other,
skin.
and subcutaneous?
Okay? Subcutaneous is a very, very short needle. The most common sub-Q medication that is given by patients to themselves is insulin. That's given sub-Q, a very tiny little needle, yes.
Doing one of the makeup e-workbooks today, they gave an example of a patient who is a diabetic, who was low on, who was a hypo.
Okay, but I don't want to get into that. Different
They
lecture.
put in, they said they have a tube for like glucose that you rub.
We didn't get to it. Relax.
Rub it.
inside.
Relax. We'll get to it.
I would just rub it.
All right,
Isn't that
Sublingual.
transdermal?
guys.
No, it's under.
Guys, relax. We'll get to it. I will answer your
I'm
questions.
just thirsty for knowledge,
This is good.
you know?
This kid looks like he's thirsty for something else.
Here we have a list of drugs that are administered. I'd just like to remind you that in your dark blue book, I created a table that has a pharmacological table that has a lot of information. I don't particularly going to go through it tonight, but just so you should know that there is a table called Pharmacology that has details on all the drugs I'm going to speak about tonight.
So page 48.
Okay? So you don't need it right now, but just know that that is a go-to place for you. Okay?
Thank you.
So, EMT medication. These medications are medications that in New York State you are allowed to carry and administer. And we're going to go through each one. There are two medications that you do not carry, but you're allowed to assist the patient with them based on certain criteria, and we're going to talk about those two. So this is a list of what's coming up. All right. Before we start that, this is a new slide that you don't have. So before we start that, I want to talk about pulse oximetry. Pulse oximetry is a new-ish device for EMTs. Paramedics have been carrying these for as long as I can remember. And now EMTs are allowed to carry pulse oximeters. So let's talk about it briefly. Let's understand what they are, what they do. Okay, number one. If used correctly, they can be a tremendous tool. If used incorrectly, you can make a huge mistake. So let's remember now that pulse oximetry is not as easy as it seems. Okay? To use it is real simple. They come like as small as that, little clip. You can buy them now for $30, $40 and on Amazon, and you just clip it over somebody's name. real easy
Yeah,
to
they have apps
use.
that claim to be somewhat accurate as well.
Okay, I don't know
Using
how,
the camera.
I don't know how accurate they are with the camera and the phone apps, I don't know. However, but I want to bring out and point out to you the problems with using them. And the reason probably why EMTs were never allowed to use them all the years. Okay, I'm not a big fan of EMTs using them. I'm not a big fan of the medics using them because I don't think they really understand how they work. A lot of them, okay? Here's the deal. Here's the deal. Pulse oximetry typically gives you two numbers. The SpO2, which is over here, which I'll explain what that is, and the heart rate. Okay? So heart rate, what's happening is EMTs are coming into a house, they're pulling out this little thing, and they're sticking it on the finger. What's the heart rate? It says 78, must be 78. Well, here are the problems with that. Before I get to the real problems, here's the problem. 78. Is it regular? Is it irregular? The machine doesn't know. The machine has no idea. The machine's taking an average of what it's feeling. All right? So we don't know now if they're regular or irregular.
And at the current
Okay.
second, no? We're taking an average at the current second.
No, it's taking an average over the amount of time that you've got it on the finger. Okay? So my first question always is, regular or irregular? Okay? Medic can see regular or irregular on the monitor. All right? How's an EMT going to know? Is it important for the EMT to know?
Because you see this.
Absolutely. Yeah, I can see the EKG strip. That doesn't give me one. So how do you know if it's regular or irregular?
Check.
Bottom fingers in.
Right? The only way to know is to
Check.
palpate. Thank you. We're using big words now. I like that. The only way is to palpate and to actually feel the pulse. So there's problem number one. We didn't even get to the oximetry part. All right. So what is pulse oximetry? What is SpO2? That's the way it's written correctly. Capital S, small p, capital O, small 2. SpO2. And what is the number? What does it mean? Well, very simple. It means how much of the hemoglobin is saturated with a gas. Interesting. How much of the hemoglobin is saturated with a gas? We're assuming that it's oxygen.
Could be carbon.
Unfortunately, the machine doesn't know the difference. Therefore, look what I write at the bottom. And we'll talk about some of these things. Right? So CO poisoning. We know already, what does hemoglobin prefer? CO or oxygen? Which one? Carbon monoxide. Loves the stuff. Right? It'll 250, I think, times greater affinity for carbon monoxide than for oxygen. Okay? Now when you put on your device and it's reading 98 or 99, okay? Could that be that it's filled with something other than oxygen?
Yes.
It's yes.
What's the point?
Right, it's only measuring
Utterly
gases.
useless.
It's not measuring anything.
It's not completely useless.
Yeah.
Hold on. I'm just giving you, I want you to know the pitfalls. I want you to know that there is a downside to it as well as a good side to it. Let me finish, you'll understand. It measures the blood, it measures the hemoglobin in the arterial blood as it is pulsating, as it is moving. It only works on moving, flowing blood. What happens to somebody who's outside in the cold and their hands are turning a little blue and you put the pulse ox on? You think they've got good blood flow at the extremities? No, they don't. We're not going to get a good reading.
But it's only the extremity, even though the rest of the body, it might have.
But that's the only place that it goes.
Right.
What about the lady who's wearing...
You'll get a good radial pulse?
Sure. What about the lady who's wearing red nail polish? The way this works is that there's a light that goes from the top of this to the bottom of this, and it reads the wavelength and can calculate the hemoglobin saturation based on getting through the nail and getting out the other side. Red nail polish
Or block it.
locks it, messes the whole thing up.
What shade of red?
So there are issues with it. It's not, guys, it's not as exciting as it looks. Me personally, I'll tell you when it works well, when you have a patient who's having difficulty breathing, the EMT puts it on and sees SpO2 of 76, okay, gets on the air, says, I need medics, I have a patient who's hypoxic. That's great. That's great.
We can give
Here's
oxygen.
where it doesn't, you should be giving
Then
oxygen,
if
of
you give
course.
oxygen and it goes up.
Of course, that's fine. Get medics rolling anyway. Here's where it doesn't work. The asthmatic, typically, what did we say? The asthmatic has a hard time getting air in or getting air out?
Depends on who you are.
Out. Most
Yeah, this should be
asthmatics
spelling this
have
too.
expiratory wheezing. Most asthmatics have an expiratory problem. So, are they getting air in?
Yeah.
Is oxygen being filled in their hemoglobin?
Yeah.
Are they dying from this possible asthma attack?
Yes.
Possibly. But they're showing 98. So you're like, oh, you're good. Right? Guy can't speak. The guy's tripoding. The guy can hardly speak 2 words together. But hey, he's got SpO2 of 98. He must be good.
But why would he be having an
I hate
SpO2
this
of
pulse
98?
Only
If he-
because the meter is not telling you how much oxygen is in the blood, it's telling you how much gas there is.
It's
you know?
not a representation of the ventilation or the respiratory system. It is a simple number that can be added to your vital signs to build the picture of what is going on with the patient. However, it is not an end all, 98, he's good, let's go.
Do EMTs use this? I mean,
Yes, more and more now. Now it was just
For what?
a,
I'm still not
They
sure for what.
slap it on everybody as soon as
for
they get in the
what though?
bus.
What is it giving?
It's supposed to give a pulse and.
But it doesn't. We
Right.
just learned.
Well, that's
the
not
pulse it
it's so
doesn't
inaccurate,
give
why-
always, especially in the cold and especially if they have poor circulation to the extremities, and these don't work on pediatrics.
Every lady it doesn't work for.
Right, right.
Point of it.
Every time I've seen a patient, there's always a pulse ox on their finger. First thing they
Point of
do
it.
is slap it
Wasn't in the
on.
book.
No, maybe does this connect to a machine for medics to be able to read also?
No, that's it.
Doesn't connect. This is it.
We do it on a machine, yes,
No,
our
this is
machine, but it doesn't give us any more information than this.
Oh, yeah?
Alright, let me move
Just
on.
put it in
I have some questions to clarify. After you do radial pulse, do you want to leave it on while you're treating the patient just to maintain, to keep it?
Absolutely no problem. No problem. But it doesn't listen to lung sounds. It doesn't tell you if they're wheezing. It doesn't tell you if they have rales or if they're... What it tells you is if you get a low SpO2 and the patient looks like they're having a difficulty breathing, that's a great thing to tell the medics when they arrive, look, we got there, an SpO2 of 72. I put them on high flow oxygen, non-rebreather, 15 liters, now it's up to 86. Do something, help out, let's go, let's do some more. Right? That's great, that's great, that's great BLS.
What number should it be at? What should it say?
Very good. What should it be at?
But
Very
doesn't-
good.
but wouldn't it give a full
Ideally
sense-
100. but-
Doesn't that give a full sense of
96.
not security, but like you did something, like you said? And what if you have an asthmatic? What if you have all those other problems? You're in your head, you
Right,
did
so
something
that's
and really
why,
It's good.
listen, we teach medics a simple line in medicine. Treat the patient, not the monitor, okay? So if you have a monitor and it shows flat line, but the patient's talking to you, is the patient alive or is it dead? The monitor says they're dead. Are they alive? They're talking to you. So obviously there's a problem with the monitor, with the leads, with the whatever it could be, but they're alive. So don't treat the monitor. The same thing with this. If your patient is in a real bad state, that they look horrible, they can't breathe, you hear the wheezing, for example, I'm just using that as an example, and you slap on this and it says 98, and you're like, boys, we're good to go, stay home. You're not having it, but he looks like he's about to die. Then go with the patient, the way the patient presents. This is it. You're gonna use them wherever you work, if you join a volley or if you, whatever you decide to do, if you work, you will end up with one of these. When I started, these were $400 or $500 each and they were the size of a brick. Okay? Now they're $30, $40 and they're the size of their fingertip. Okay? So things have come a long way. I'm not a big fan, you know? They're good to see progress. Okay? Patient looks horrible, fine. We need to get them oxygen. Quickly, get on the pulse ox, get them the oxygen, let's see where they're at.
Is it good, let's say, for secondaries? Like to keep, to keep them.
Well, we didn't do medical patient assessment yet, so let's not mix things up, all right? All right. Cyanide poisoning, same thing. A lot of CO is produced where there's, burning carpets or drapes or these type of things. Cyanide poisoning will also give you high SpO2 numbers, and CO poisoning, carbon monoxide will certainly do it. Okay, so again, treat the patient, look at the patient, and that's really all I want to say. One person asked, I think Ari asked, what is an optimal number? We want it to be over 94.
How much gas is in the blood?
We want it to be over 94. If it's over 94, we're pretty confident, we're pretty comfortable. Remember what it means? It means that 98% of the hemoglobin is saturated with, hopefully, oxygen. 2% isn't. Same thing, with 94% saturated with oxygen, 6% is not. We're okay with that. So if we get our patient up to 94, then we're good. Then we're going to transport the patient, figure out what's going on, maybe get medics to help us, but we're good. Patient's stable at 94 and above. Okay? We're not looking ever for 100. It's not necessary. We'd like to see over 94. Okay? Alright, so that leads us right into oxygen, which is the treatment for hypoxia. Remember, hypoxia is noted on a patient by blue, right? Smurf, as we've said before. And last night we introduced the words mucous membranes. Mucous membranes. Okay, this is the mucosa, it's known as, the mucous membranes. This is anywhere that you peel back, pull back, and you actually see wet tissue from the inside. So in the eyelids, in the mouth, these are mucous membranes. These are places where you may notice hypoxia, but you won't see hypoxia written over there. You'll see cyanosis. Okay? So oxygen is a drug, as somebody asked earlier.
If you have to take out the lip, or
Just pull it down, yes. Take a look. Predominantly, by the way, you have this problem with African Americans and dark-skinned patients, right? On white people, we turn blue all over, right? So we turn colors. So it's easier to see. All right, it's inhalation. Oxygen is inhaled, right? You've seen some of the masks that we use. Typically, we're going to use 15 liters per minute with a non-rebreather or a BVM. This is just review. We know about the oxygen and oxygen delivery, right?
Isn't the contraindication also though hypoxic drive? But there's no way we know.
No, it's not a contraindication. Told you that in the lecture. It's not a contraindication. You will still give oxygen. You're not going to be with the patient long enough for the hypoxic drive to have a problem.
Theoretically, it would be. It's a problem.
Let's remember. They will ask you this on test questions, and the answer is treat them like any other patient with oxygen. Okay? All right. Next drug we're going to talk about. So this falls into both categories. It falls into the category of drug that they may have at home that you can assist them with, and it also falls into the category of drugs that you carry. So both. This is what they may have at home, okay? This is called a MDA, a metered dose inhaler, okay? Here, take a look. Don't inhale it into your own mouth, okay? Metered dose inhaler. Pull off the cap, make sure you can give a squeeze, just not at yourself or your partners.
Does that one have a counter on that?
Yeah, some do. This one doesn't. Okay, don't. This one doesn't. All right. This is called an MDA or a metered dose inhaler. Asthmatic patients have these at home. Asthmatic patients are prescribed these. They carry them with them. I've seen a guy with one on a Shabbos Bendel. Okay, drilled 2 holes in the top and bottom. I've seen that. Not joking. Okay? Honestly, probably allowed to carry it if he needs it. Shabbos that regularly. But I guess the Rav he asked, told him this is what he should do. So he did it, yeah.
What's the Shabbos Bendel?
So,
Forget it, it's patent.
How do you expect to know what that is?
Is that the generic name?
Look at Ducky.
It's part of the new slides.
Shabbos belt.
Lucky that one.
I didn't know we had Syrians in the class, so we have to translate Yiddish
Secret
words.
agent. We don't know a lot.
47 is a Syrian name. You never heard that?
47, I guess. Secret agent. All right, he's undercover Ashkenaz, right? Not doing a very good job with the undercover, but okay. All right. So, people have these at home. Patients have these at home. They may be sitting in the couch and they literally can't breathe, and they're pointing over there to the bookshelf or to the break front or whatever, and they're telling you the kitchen, inhaler, get my inhaler, right? So it's much quicker to get their inhaler and give them a puff of their own inhaler than you setting up yours, which I'll explain how you're going to do that in a minute. But this is much quicker. Get the medication on board quickly. So this is the first assisted drug that you're allowed to assist them with their own drug. It doesn't actually matter what is inside here. If it comes in a metered dose inhaler, such as that, you have to make sure the 6 rights, which we'll talk about in a minute, but you don't have to worry, oh, well, it says this name and I'm only allowed to give that name. No. If it's a metered dose inhaler and they need it for breathing, respiratory problems, you can administer it. Just one thing, I do not have one in this kit, but this piece here is called a spacer. A spacer. Young children cannot, for some reason, when you give that spray, the young children don't realize that they have to close their mouth, hold it, and breathe it in. And basically it just gets wasted, just spraying it. So they have this piece called a spacer, and it has a mask on the end. This picture will need to be improved. Has a picture of the mask on the end. And you put the mask over the child's face, the spacer, and then the metered dose inhaler. You give one spray, like at the top. You give one spray, goes into the spacer, hold it there until the child next breathes in and out. Once he breathes in and out, it will not be lost in the air because it went into the spacer, and he will get the medication.
One breath?
One puff. Again, you can see what the directions are for that patient. If that patient's supposed to get 2, give them 2.
I'm saying, but for the
Whatever it says on that patient's MDA.
okay. Spacer.
Still 2.
Saying you only finish it. In
Still-
one breath, you finish the whole thing.
Yeah, one breath, he finishes the whole.
But they're
What about age? How young?
Age?
Yeah, how young can you give it?
Oh,
Technically,
over 1 year old.
You
can
don't
already
need it, but
use
technically anybody can use one of those. It doesn't. That doesn't affect.
What anybody could use a spacer, but typically you don't see it. Once they reach 7, 8, 9, 10 years old, you're not seeing spacers anymore. You're seeing it in the younger population.
what if he can't breathe? Like I was there getting camp, but wasn't able to breathe. He was breathing so fast. He had like 2 puffers. He's like trying 2 of them, and he couldn't breathe it in. What do you do? How do you just like force it in? Is there any way? Like,
That's also.
right.
I was talking
Like,
about
calm it down.
medication. I'm not-
Hold on.
Okay.
This is just using their medication. You also carry this medication.
No, I'm talking about the
Let
one.
me get to
How
that.
do
Let
you-
me get to that. If they can't use their own is only just to save time to get things moving. This is not the treatment, okay?
There's no general rule about what medications you're allowed to help them with.
Yes, there are. There are only 2.
Oh, okay. So then-
This is number
so it
1.
goes by name, not by category. There's no
Yeah.
category.
Anything that comes in a metered dose inhaler
Okay.
that's used for respiratory problems, you can help them with.
Meaning albuterol is the most simplest form, but
Okay, but
there's many
you
others.
see that I'm not
an NDA.
using the name
I know
yet
that.
because it
You want-
comes in NDA. Many drugs come in NDA. I don't want to start confusing you with all the names of all the drugs that come in the NDA.
This is not the same thing as MDMA, right?
Not the same thing. Okay?
That I carry also, but I.
You do?
Yeah,
Okay.
At what age would kids start using
Meter dose.
One.
one?
Yeah. Usually not before one. Okay. Now let's talk about what EMTs carry. Okay? Yeah, I'll take that back. Thank you. So EMTs don't carry these. Obviously, these are for specific patients. Meter dose inhalers. Sorry, MDIs. Was I saying MDAs?
Yeah, I was.
MDI, meter dose inhalers.
You had to ask.
We thought it was like maybe like the bee pneumonia or something.
It's the game.
I got the point.
I'm off my game. All
you
right,
have another.
Maybe
now,
maybe it was an inhaler with an A.
maybe. Thank you. This is what you carry. Okay, comes in a box like that. Albuterol sulfate. Okay, you carry this albuterol sulfate. It's the only thing you're allowed to carry. Many drugs come and look like this. Make sure when you get it from your restock that you're taking albuterol. Medics have other drugs that come packaged the same. Okay? Not albuterol. Okay? So you want albuterol, that's what you should be carrying. Each inside this packet is one dose. Okay? So I'm going to open it. And you're going to pass it around. Each one of these is one dose. Okay, you do not need to learn the dose. For the New York City medic exam, they make you learn the dose, which is 0.083. 4 answers, 0.83, 0.0083, 8.3. I'm telling you, this is a real question on the New York City medic exam. What is the dose of albuterol? And that's how nuts it is,
It won't be
okay?
by us though, because they don't have.
You don't have a New York City exam. This is one vial of albuterol, came out of here. Check the expiration date, we'll talk about that later. You pour this entire thing, don't do it. You crack this off. Also, many of them have a nice big A at the top, you'll check that out. Okay, A for albuterol.
I for albuterol.
I is for ibuprofen.
No, I is a different drug. Tropium, that's right. Okay, you're not allowed to carry that. I carry that. A, albuterol. Okay, comes out of here, you break the seal, you squeeze the entire thing where? Where do you squeeze it?
Nebulizer,
To your
nebulizer.
nebulizer, very good. You attach your nebulizer to oxygen. How much?
4 to 6 liters per minute.
Between 4 and 6, or what's the real way to know how much you need?
If it explodes, you went too
It's
high.
misting.
Misting. Hopefully you don't go too high, all right? So pass that around, take a look, show everybody.
Yeah, we
Everybody
tried
take
that.
a look.
We tried that.
Now-
I don't know what a group knew.
Now let's talk about the drug. Guys, while you're passing that around, taking a look at it, let's talk about the drug, all right? This is a phenomenal drug. It really works well, and you must know this, how it works. It is a bronchodilator. Now, if you don't have that word, you need to write it down, highlight it, whatever, learn it. Bronchodilator. They will ask you this question over and over. How does albuterol work? It is a
Bronchodilator.
bronchodilator. Why is that good? Why is that good?
Dilates my bronchioles.
So why is that good?
Because I can't breathe if my bronchioles are spasming.
Well, you can't transfer oxygen.
Let's take the I out of it. Let's talk about what is going on during an asthma attack. What's going on?
The alveoli.
Constricting. Broncho, what's the word I used? Bronchospasm. No one remembers that? Bronchospasm is the word I used. And yes, they are constricting, and they're constricting and getting tighter and tighter and twisted and tighter. What are you doing?
Making it larger.
Making it larger.
Which
Bronchodilation.
allows more oxygen to transfer through and into.
And let them breathe again normally, right?
Question.
So,
If the bronchioles are constricting during an asthma attack,
yeah.
how are they able to inhale but not exhale?
Well, the reason the reason you hear the wheezing, they're having a hard time on inhalation and exhalation, but you hear the wheezing usually on exhalation. Because
That's where the effort is? That's
the effort to get out through the mucus and through the twisting, the bronchospasm, that's what's causing that whistle sound, that wheezing, typically. You can have patients wheezing on the way in also. Just more likely that it's expiratory wheezing. More likely. Okay? You can have both.
But you were saying also that
That SATs can be very high, yeah. Because they're able to get some air in. They're able to pull the air in.
It's just on the exchange because on the exchange that's lost.
Okay. Very new piece of equipment that EMTs are now permitted to use and carry. New York State, New York City. Okay? New piece of equipment. It's called a glucometer.
Oh.
And this is used by withdrawing one tiny drop of blood, usually from the tip of the finger. You have disposable sharps that you will just jab quickly into the finger. You make sure you clean the finger first with alcohol. You make sure you dry the finger first with non-alcohol, with a 4x4. People forget this. So basically, if you don't dry the finger, you're testing blood mixed with alcohol, right? So you're not getting a true reading of the blood pure. It's capillary blood. This is not arterial or venous blood. And these machines are calibrated to read this capillary blood, all right? You get one drop, you need a full drop of blood on the finger. You bring the machine with a disposable test strip up to the blood. They usually suck enough blood in on their own. You don't have to do much. All you got to do is just get them underneath the drop of blood and it will suck in what it needs. And within 5, the old ones were 20 seconds, now they're all 5 seconds, you'll get a reading. Great, now we've got a reading.
It's 2 pieces? You prick and then you put that on?
3 pieces. There's the thing you prick with,
And that's a separate
disposable. There is the test strip, disposable. And there is the machine,
Which is not.
not disposable. Well, they really are, but okay? All right. So, the most expensive part of this whole setup are the test strips.
Really?
Machines are given away almost free by drug companies and test strip producers. They'll give you the machines. They'll give you the machines, they'll give you 10 strips, and then when you go to buy your next set of 30 strips or whatever, you're like,
$2,000.
whoa, really? They're expensive.
Besides diabetes.
Okay? So, glucometer is going to give you a number. The number it's giving you, and we'll talk more about this, not tonight, when I do the diabetes lecture, we'll talk more about this, but the number it gives you is how much sugar is in the blood. How much sugar is in the blood. Now, here's where things have changed, and here's where I'm going to tell you the old way and the new way. The way I always taught EMTs to know what was a good normal range was to think of blood pressure. Blood pressure, normal blood pressure in the textbook is 120/80, right? So I always told EMTs so they wouldn't have to learn more numbers. Just remember, from 80 to 120, you're good. That's a good blood sugar, okay? Here's the problem. Here's the problem. There was a major shortage of dextrose. That's the stuff the medics use to raise sugar levels through the vein. There was a major shortage in New York City. Major shortage. So they did some research and they found out that anything above 60 is good. So they've lowered the bottom range where it used to be. So now in New York City, from 60 to, you could still say 120, is the normal range of glucose in the blood. We call this a BGL, blood glucose level, BGL. Okay? Anything above 120, which really it says here,
Now, what is that level? What is that level?
we'll get to it, not tonight. Tonight I just want to talk about this machine. Now, why are EMTs allowed to use this when they weren't allowed to use it all the years?
A lot more diabetics.
So they can give the sugar on the tongue.
Yeah, but you could have done that anyway. Okay? See, the next slide is what you carry to help diabetic patients, okay, with low blood glucose.
What do you do with the test strip again? What do you do with the test strip?
Test strip goes
Okay,
into the machine,
And it gives you a reason.
That's how it gives you the number?
and it goes under the drop of blood, okay, and then it gives you a number in the machine, then you throw that in a Sharps biohazard container, okay? I'll show you, I have one downstairs. When we do a skill night, I'll show it to you. Okay, so let me tell you what the rule used to be, and then I'll tell you what the rule is now. It used to be, it was much better, okay? You come on scene, you see a patient who you know is a diabetic, you were told is a diabetic, they're wearing a bracelet, tag, you know, Medi bracelet thing, and they're still conscious, you give them glucose. Right? It was that simple. Okay, if you knew they were a diabetic, someone tells you they're a diabetic, their AMS, ultimental status, we'll talk more about that another night, give them glucose. That was it. Okay, so it didn't matter. It didn't matter what their number was. Now we're telling EMTs that you should check the number. If it's below 60, give them glucose. If it's 60 to 80 and they're still showing signs of hypoglycemia, AMS, etc., give them glucose. Okay? Above 80, they're saying they'll be fine. So they've still got that 80 as a backup number, which is where I used to say that was the go-to number. But you never were able to check. All right?
Too much glucose is not bad.
Very good. So now we're going to address what happens if they were at 500-600 and you gave them glucose. Okay? What happens?
500-600 what?
This number, the BGL. Okay?
You're holding the meter upside down.
No.
How do you get to 500?
Listen, guys, let me explain. Let me explain.
The normal is 125 is high.
So if zero, let's think about a sliding scale for a minute, all right? Let's say 0 is death. Okay? Let's say 60 to 80 is the lowest of normal. How far is it from normal to death?
60.
Right, is that a large number or a small number?
Depends in relative what the
In
other.
relative to 800. It's a very small number. And this is why EMTs don't need a glucometer. Because you see somebody, they meet the criteria, give them the glucose.
What is this?
Get to it.
Yeah, but 800 is not death either.
Well,
No.
he's saying you have a lot.
Guys, let me finish. Again, if 60 is the lowest normal and 0 is death, okay, now that could be 20 also, by the way. 20, 10 could also be death. But let's just say 60 to 0, very small window. Very small window, give them glucose, right? We said that normal, that diabetes is over 125. Okay? That 125 goes all the way up to 600, 700, 800. Nobody dies. They can be very sick, and we'll do a lecture on this in a later date. Can be very sick, but no one's dying acutely from high blood sugar. Okay? That takes days, hours, weeks, maybe months. So no one's dying right there and then. Hypoglycemia, on the other hand, people die all the time. If they're not found, if they're found too late. So do you understand why, in my opinion, there's absolutely no need for EMTs to carry glucometers? There's no need. Meaning, use clinical judgment. Again, we're going back to relying on a machine that, yeah, it's pretty much always right.
But it's
I'm
a
not
bad-
going to say the
but it's a ba-
machine.
It's a bad crutch, though.
Yeah, the machine's not going to give you a wrong number. There's not a bad time to use it or a worse time. No, none of that stuff. Like with the Pulse Oximetry, it's always going to be right. I mean, they don't work if you leave them in the cold. I'll tell you that. I carry 2 in the winter, one inside in my jacket pocket, one in the car in my regular equipment.
Carry one in your Bendel.
And any cord screen is gonna have that issue. It's not the meter, it's the screen that has the issue. In the cold weather, those screens don't work.
Okay. Or my rule, if we spend too long on one slide and it went off, then we should move on. Okay? That's my rule. So, so let's say you don't know, and they're really hypoglycemic, they're at 300. And you give them a tube of this. Okay? So what, now they'll be at 400? They're still doing just fine. Alright? They're still no worse than they were at 300. And if you put them from 400 to 500, they're still no worse than they were.
So how much of a difference does the glucose really
Depends on the patient. Okay? Alright, let's talk about the actual drug. The glucose, here you go. Pass it around, take a look. Looks like a tube of toothpaste. Again, it breaks off, it's 1 dose. I'm pretty sure there are 15 grams.
They take the whole thing?
What?
They take this
They
whole
take
thing?
the whole thing. Now the best way to give this. Stop. Listen, because you're gonna mess up if you don't listen to what I say. Listen. You can only give this glucose to a patient who is conscious. You may and must never put anything into the unconscious patient's mouth. Is that very clear? If you're in the middle of giving it and the patient goes unconscious, what do?
Take it out.
Stop and get it out.
Suction.
Sweep it out. It's too thick to suction probably. Sweep it out. The best way to give this is you go in, usually you're in a person's home, apartment, house, find a cup of orange juice, grape juice, apple juice. Squeeze that whole tube into the cup, stir it up. Now give it to the patient. Do not feed it to them. If you're feeding it to them, they fall into the category of they shouldn't be getting anything PO. Alright? That's an EMS tip that you will not see in the textbooks, okay? If they can hold the cup and drink it on their own, then you're doing right. And the best way to do it is to get apple juice, orange juice, grape juice, any of the sweetened juices, squeeze that in, mix it up, and tell them to drink the whole thing. No diet soda allowed. Okay? There's no good putting this into Diet Coke.
So this doesn't mix well with like vodka.
Regular Coke is fine?
Well, it mixes well with vodka, but
Anything
Give them
does.
a good
sugar. It's pure glucose.
sugar.
You can put it in your coffee.
Does it taste
put 'em
nasty?
15 grams
Why do you
though.
put 'em
It's nasty.
It's like
It comes like a fruit punch.
It's like a
a
thick.
Gatorade
Do we
in
carry
syrup
this in our
form.
equipment
Yeah,
bag?
thick.
Is this something that we find in our
Thick,
equipment bag?
Yes.
Syrup
Yes.
Gatorade.
You will all carry this in your equipment bags. Okay?
It's a goop, is what it is.
Now,
You don't,
the book will tell you about rubbing it on the inside of the cheek and all that stuff. We rarely do that, okay? Usually, the way I told you is the way you do it. If you're in a place where there's no cup, no juice, no spoon to mix
What
it,
if they can't hold it?
if they can't hold it,
You don't give
nothing
it.
PO.
You don't give it.
Why is that?
You tell me.
Because they're not conscious enough to drink it?
Okay, and what's wrong with being unconscious?
So it'll go down the wrong
Very
way.
good.
Choking.
Very good. So again, if you're in a place where all you've got is you're in the back of the ambulance, let's say. They walked in and then they went, right, AMS on you, which really doesn't happen that quick, does happen quickly, and you've got no juice, no cup, no nothing. You take this, you open it up, and you squeeze it inside the cheek. Yes, you can squeeze it into the cheek. But don't put it on your finger and start rubbing it inside.
Stick it down.
No. Okay?
They may want you to do a lot more if you did that.
So that's glucose. Next.
Later wants to try it.
Please don't.
Oh, yeah.
You don't have that with you, can you just give the guy sugar?
How do you know
Yes.
how do you know if the patient's hypoglycemia?
Definitely not kosher.
Eli, how do you know if the patient is hypoglycemic?
Really?
Glycemic.
You have a glucometer now.
No,
If it's
but
less
without
than
the-
60. Without the glucometer,
Yeah.
we will do the signs of AMS, hyper later.
Okay.
Not tonight, I said that already. Okay? Tonight we're dealing with the drugs that you carry. Okay? Has everybody seen that? Has it gone around?
Here.
Almost. Here. This is an aspirin. Okay?
What does that look like?
What's that?
Chewable.
Aspirin that we carry in EMS is a special type of aspirin. Okay? It is called 81 milligram chewable aspirin. Nothing is given with a glass of water. Good. Nothing is given with water or, swallow this or whatever. There's only 2 instances where you can give your patient something to eat or drink. Here is one of them. You can give them a cup of orange juice, okay? This is the first of 2, right? Aspirin is 81 milligrams. Guys, remember this. 81 milligrams. New York State allows you to give up to 4. Total dose, 324 milligrams.
Is that a number?
Gotta remember this.
New York State.
New York State, that's the course you're taking. New York State, that's what you gotta remember.
It's 4.
324 milligrams, 481 baby aspirins. That is the dose. Now, who gets this and why do they get it? Very simple. Any patient that you think is having a cardiac event, such as possible MI, right, a myocardial infarction, which we're going to learn about later tonight. Any patient that is having cardiac event, you should give them 324 milligrams of chewable baby aspirin. Okay, it's given PO, and you give it to them and you tell them to chew it up. Okay, not to swallow it, but to chew it. So, a question that I get asked all the time. What happens if you get on scene and they tell you that they just read a few months ago in the New York Times that if you think you're having a heart attack, you should take an aspirin, all right? So, nobody has typically these chewable aspirins at home. They have regular 325 milligram aspirin that they drank and took with a cup of water. How quickly do those work? Approximately 45 minutes to an hour until that gets into your system, right? We want something to work much quicker in an emergent situation, and so we give the chewable aspirin, and you can assume that they haven't taken any if they took one like that, okay? And just give them the chewable aspirin. It is not for the pain. It does not work on pain, on cardiac, on chest pain. It works because it
blood thinner?
it minimizes clots. It's an anticoagulant.
Is it a blood thinner?
Anticoagulant. Okay? It does not take away from the clot. It does not take the clot away. It just prevents a worse clot from occurring. Soon, later on tonight, we will do cardiac emergencies, and you'll understand more about it. For now, just understand, it's an anticoagulant. You need to give 4 if you think that they're having cardiac chest pain, and the total dose will be 324 milligrams.
Question? Why does the chewable work differently and quicker?
Because it gets broken down, goes in through the mucosa, and it goes much quicker and starts working rather than the swallow. It's not going through the GI tract.
Wouldn't it be quicker to try anything,
Advil, anything?
No, they don't work like
What
that.
should you do if they told you
We just chew one of those.
You can chew on regular ones also.
Find out, I just told you.
I know, I didn't hear what you said.
Give it to them anyway.
You should.
Yeah.
You could chew
Why
very
don't they have a
well.
nasal
Up to 4?
aspirin now? Would that be quicker?
It's not common in EMS.
You move.
All right, next drug. Come on, I want to move on. We got a lot to do tonight.
What are we doing from
So it does not prevent
Next drug.
But yeah, different ones now, no?
Oh yeah, they don't have any EpiPens anymore, right? It's too expensive.
Catch.
I have 5 of them.
The next drug is epinephrine.
Covering some things.
Epinephrine, listen, I'm just going to say this quickly. Not going into it because this is not the night for the problems, this is just to learn about the medication. Epinephrine does 2 things. Let's start with what it does, because you will be tested on this. Guys, epinephrine does 2 things at the same time. It is a bronchodilator. What else does that? Buterol. Very good. Buterol. It is a bronchodilator and at the same time a vasoconstrictor.
Oh.
So now this is doing 2 things. Okay? When would we want vasoconstriction? In what sort of problem? Shock. Which type of shock?
Hyperperfusion.
Don't listen to what he says.
Allergic reaction.
What's the general term?
Anaphylaxis.
What type of shot?
What is the general term for the type of shock where we could use vasoconstriction?
Hypoperfusion.
Something genic. Something genic.
Distributive shock. Okay? Alright.
Did we just all fail?
Yeah. So,
What was that word
Distributive
again?
shock.
Vasoconstrictor?
Vasoconstrictor. It's in the slide.
That was a dinosaur.
okay. So, epinephrine, or known for short as epi, in all other parts of the world it's known as adrenaline. Okay? Nowhere else calls it epinephrine, only in the United States.
Specifically the myelin trait.
Adrenaline.
Yeah, used here in the United States. Everywhere else in the world calls it by the generic name, which is adrenaline. Okay?
Good name to trade.
So, again, you must know these 2 attributes that it has.
Bronchodilator and a vasoconstrictor.
Bronchodilator, vasoconstrictor. It is typically used for 2. No, Ephraim, no.
Yeah, I just.
I'm just showing how to use it.
No.
Oh my gosh, I said that's like that's where the needle comes out.
It is typically used for 2 things. Anaphylaxis and extreme asthma attacks where the albuterol isn't working. Okay? You see the connection with the albuterol? Because this also is a potent bronchodilator. So if the albuterol isn't working and your patient, you've given them 2 doses and your patient is really doing poorly, you can go with the epi now.
What do you mean by poorly?
Bad.
No, what his respiratory rate is.
Yeah, everything's getting worse.
And you use an epi?
Yes.
You tried albuterol, it doesn't work. You see,
Epinephrine is
After what time span? After what time frame?
distributive shock.
right, and how long?
After how long did you realize,
When
oh, my patient's
the blank is not working.
How long do you have to give that albuterol to work? And your second
It's not working when that's
5 minutes for each
Oh, you mean
albuterol.
when the albuterol's not working?
Albuterol works instantly. Or doesn't.
So 10-15 minutes later, he's
Yeah, 10 minutes,
stress.
What was the first one? When is it used?
It says here, anaphylaxis, severe wheezing.
No. You
Says. Next, I want to say one more thing.
Yeah.
The needle comes from the orange part.
There's no hole though.
Not in this. No, this is a fake. These are testing.
It still comes out of the orange thing.
No.
On that one.
My son actually thought he was playing with a fake one and he stabbed himself once.
Oh, you went to the hospital.
No, because it didn't go in.
No, because Tally knows better. He's an
No, it didn't go in. It didn't go in.
Okay.
It didn't go in. It just.
New York State,
I have
listen.
to report that.
Listen.
Yeah, that's okay. It was a lot of fun.
New York State has a rule.
Epi is one dose.
What's the difference?
Epi is used once.
One's child, one's
chocolate.
adult.
Yeah.
White's child.
Orange, what's blue?
The blue's a test. You could do it.
This is given IM, right? Let's talk about how you give it. Give me one,
Is
please.
this considered a, this is also, this is
Give me
not
one.
MDI?
This is real?
Yeah. And just like that.
Yeah.
Not a test?
No, those are real.
Oh,
Yeah, this is a
The yellow's
real
a
one.
Oh my
child
gosh,
one.
I was gonna stab myself with that.
No, this one's.
The
That
yellow's
one's
a child one.
No, but they're real. They have needles.
Of course
and
they
This is a
do.
real
That one doesn't have one.
That's
Then-
a tester.
I know,
This
but I'm
is a
saying
test.
There's no what's
thing
it
is, I was
called?
like about to like you know.
If there's no
Hilarious.
there's no glass or whatever.
That's why he's like, I don't know, like, show them how to use it.
Came out?
Yeah.
Oh my gosh.
Yeah, I don't want anyone to use this. Now they won't be able to use it. What did this idiot give me a real one for?
Here,
And they're
here's a fake
expensive.
one.
They're expensive.
Here's a fake one.
It's gone now.
They are expensive.
September 15th. It's fine.
That one made. That one's
It's
not
real.
a
It's
tester.
real. I know.
So why is he? This is the only tester, right?
Anybody else stab themselves?
Where's the real one?
You
want
had a
the
real
fake one?
one.
Oh, I missed it?
Here, here.
Did you do
Here's
it?
the cap for the tester. Sorry.
Thank you.
You should put that on your Shabbos, what was it called?
Bendel.
Bendel.
Okay. This is given IM. It's given in the lateral thigh. Okay. Very easy. You take it out of the container that it comes in. Take it out. Okay. You remove the cap from the top. You never touch the orange part. Okay. You check that it's right. Okay. It's a tester. And you go in the lateral. You go in the lateral thigh. Okay. You can go through pants. You can go through a skirt. Stockings or whatever. We'll talk about that statement later when we do the anaphylaxis lecture, but for now, we'll say that they work through regular clothing. Jeans and very heavy-duty work clothing may not work through, and basically you just come here with the lateral thigh and you hold it for 10 seconds. Test question, all right? How do you use it? How long do you hold it there for?
Gotta mark that in the video, test question.
Lateral thigh.
Okay,
You do the right lateral thigh?
all right.
Why are you putting it there as opposed to the arm?
Either
Thigh. That's where you put it. It's a larger muscle.
It's a cliffhanger. I'll come to medical school if you want to find out.
Okay, new drug. New drug that has hit the streets. Everybody's got it. They're
Ari?
giving these away for free at the drugstores.
10% coupon discount.
All the cool kids use it.
All right. So,
Yeah. Prevent overdose.
so. One of these I don't have. This is brand new. State of New York is giving these out for free. It's 4 milligrams in one shot. Okay. The typical dose is 1 milligram plus 1 milligram, maybe 2 was the most really given. Now this is 4 milligrams in one shot. They're giving these out for free. So anybody but fire department can get them. Municipalities are not allowed to get them unless they buy them. But all volunteer or all small ambulance companies can get these for free. This was just very recently approved by New York City, even though it goes against New York City's
Protocol.
well, it's not just the protocol, but the dose that New York City approved was 1 milligram in each nostril. Now we're at 4 milligrams, one shot, okay, one-time use. So the problem is getting greater. You may or may not carry these. What you will definitely carry is one of these, and this is what I want you to look at. Does somebody have a small cup with a little bit of water? Can we get a small cup with some water?
What is it for overdose?
Yeah, I'll explain what it's for, what it does, everything.
Is there anything in that cup?
I don't know. There was coffee, I think.
I brought a cup today.
Okay,
Medics are here.
guys, not now. I'm in the middle. This is called an atomizer, right? This small piece you'll need to carry with you now. Every single EMT will have to carry an atomizer, all right? This goes into the nostril, and I'll show you what happens next. So pass this around quickly and get it back
Try
to
it
me.
real quick and then give it to the next guy.
The top and bottom are both Narcan in the picture?
Yeah, yes. You will carry this. This is the one that the state is giving out now for free.
So you're passing out a Narcan.
No,
No.
right now I'm passing out an atomizer.
Atomizer.
Thank you.
It's not used, right?
Okay, move up, drop.
Oh, there's
Okay,
No.
Narcan comes packaged like this. In this box, two things. There is the drug, the vial, and there is this,
The shot.
which, no, there's no needle. Hopefully, right, no needle. This is called a blister jet, when you put the two together, okay? All right, two things come in the box. The atomizer is a third item that you will have to get separate. Does not come in the box. If you get this, then it's all included in one piece. It's got the thing to go in the nose. It's got the drug built in. You just go like that, and that's it. One-time deal. Okay? This atomizer is disposable. All this stuff is disposable. So in the box, which is usually this light brownish, it's more of a brown than a yellow, you'll get these two items. This is how it works. You take this off. I need the atomizer back, please, soon.
What's the atomizer?
All right.
There are two caps, one on the top, one on the bottom. There is a needle running through the middle, but it's completely safe. The drug also has a cap. Where you all going? I'm gonna pass it around.
You wanna get in the movie, you wanna be in film.
No, sit down. The drug screws in.
The atomizer rules.
The drug
You're wearing a
screw.
good cap.
The drug screws in. Okay.
No, I didn't buy it, struck, see?
And it's
Do
empty.
you have to have, what do you, have
No.
water?
No. This one was empty. I'm just refilling it.
So you're like also a pharmacist?
Yeah.
He's a chemist.
You like Narcan with water?
Okay, so now it's full. It came out of the box. Okay, this is full. I attached my atomizer. And on the side are the dosages, 1 and 0. I think it goes down. No, it goes from 0 to 1.5, and then the one after that is 2. So basically like this. If I squirt right out of here, watch what happens. See what happened? I got a straight shoot. Everybody saw that? Yeah. I wonder if they saw it on the camera.
Shoot it at the camera.
I think it was a bit premature.
You have a good arm.
What?
I think it was premature.
It was? There's no such thing.
Talk to me.
There's no such thing.
There's no such thing.
Now, when I shoot it through the atomizer, look at it. Can you see the mist?
Pretty cool.
A little bit.
You see that?
No.
Oh, yeah,
I see.
Yeah.
Yeah?
sideways.
See it?
Goes misty as a
Mist.
Camera
That,
can't see it.
Ellie, be careful,
Shoot
don't
it at
slip
the
now.
camera.
Don't slip.
the mist goes into the mucosal membrane of the nose.
Instead of
And
coming out
gets-
watery.
You see, if you just shoot it straight back, it's just going to go straight back and go into the nasopharynx. It's not going to do anything. Okay? This mist actually will be absorbed by the...
So why doesn't that come in the same box? Why did that? Why?
Oh, very simple. Because when they invented this drug, it was only for IV use. This wasn't even invented when this drug was invented.
That's why the bottom.
They figured out later that this can be used for that.
That's why you got the guy in the bottom now. It has it all built in.
Where do you get this
You're not gonna have to do that again for Stragi.
Any of the drug
How do you get it for free? He wants to know.
The drugstore,
He's asking for a
CVS.
friend. He's asking for a
They
friend.
really give it out?
Just you walk in, say you want Narcan, they'll give you. No?
Elliot, Brian said the nimshal is that
Serious?
you last longer with misting.
Why are they giving it out for free? Because they don't want people to overdose?
Maybe true.
You You walk into any pharmacy and ask for Narcan, they give it for free?
Yes.
Why, they don't want you to overdose? Is that the idea?
Harry's gonna go every day for the next year.
I can do that,
You have to go in like this.
You can sell
get
it.
some Narcan.
If you get it for free, you're not gonna sell it.
Why not?
Because everyone can just walk into the drugstore like you
You
guys.
may not be able to sell it here. It doesn't mean it's free every state.
Okay, let's talk about
Amazon, put it back.
let's talk about what Narcan is used for.
Do we have to know the doses for Narcan?
Yeah. No, you don't really need to know the doses. 1 milligram in each nose with a repeat.
No, 4 today.
So four is in the next, is a
The 4 is only if you have this piece like that. Okay, I haven't seen these on the street yet.
The atomizer is 4.
Right.
And the regular Narcan?
Is 1 milligram, half of this
Those are your
vial
favorite.
in each nostril. Okay?
That dessert.
Okay.
This is a serious class then.
Now, why do we use Narcan? Who will benefit from having Narcan? This is really important. Listen.
This is a carbochemical, it's not a drug. You can eat that.
Who will benefit from the Narcan? Okay? Any patient who has overdosed on an opiate-based drug, such as heroin, it's only one. What about fentanyl, morphine, oxycodone, Percocet, Dilaudid? Right? These are a few of my favorite things, right? So anyone who has overdosed on any of these, who is having respiratory distress. Not, they tell you, oh, I'm doing Narcan, I'm doing heroin, give me Narcan. No, if they're all hunky-dory, if they're doing the heroin wobble, which is what they do, they can't stand straight, you think they're gonna fall back, but they don't. It's fantastic to watch them. The heroin wobble.
YouTube is full of it.
It is?
Oh, there's hundreds of videos.
Okay, but they really do it. I got patients that do it, okay? It's fantastic. They're talking to you, you're sure they're gonna fall over. And they don't. The heroin wobble.
They
right?
fold themselves in half though.
Yeah. Now, if they're doing all that and they're having no respiratory issues, don't give them Narcan.
Don't waste it on them.
Yeah. They don't need it. So who gets it? Let's get this clear.
Respiratory distress.
Who are overdosing on
Who are overdosing on an opiate, right? How can we see an opiate right by looking at them, at their pupils? How?
The constricted pupils.
Constricted pupil, that's the giveaway. Number 2 is the respiratory distress. Respiratory arrest, possibly. Okay? They do all these things. They go into respiratory arrest. Certainly want to give them Narcan. This, I see now, is too difficult to read, too small. We will work on this later date. I won't worry about it. This is from New York City. I wanted to see how it would look as a slide.
When you get on scene, how do you know it's just because it's respiratory distress?
He said eyes.
You have to understand that when every scene you come to, unless they're just drunk out laying on the street corner and some good Samaritan has called, right? On 911, somebody dead on the park, right? Unless that's happened, right? Let's take 99% of Hatzalah call. Somebody's calling for somebody else, okay? So the somebody calling is already starting to tell you when you walk in what's going on, what they do, what they didn't do. Even what they lied to you about tells you a tremendous amount that would actually happen. I mean it. Even the lies they tell you help me to get to the truth.
For example?
Oh, he was just with some friends. They were all fine. They came down, they were eating, they had the music on loud, they were, no, my son does nothing like that, no, absolutely not. As soon as you hear that, you know for sure there's a problem. Okay?
out.
You can just tell, Now, if the person is just, you're walking on the street, you're on beached Whale Avenue, and you're walking along, and all of a sudden there's somebody laying down the street. How are you going to know? First thing is do an ABC check, right? You know how to do that. Check ABC. Okay, he's alive. He's not breathing. Why is he not breathing? Okay, do I have a BVM with me? Let's help him breathe. Good. Let's look at his pupils. If you see that they're constricted, that's it. It's a game. It's game over.
Game over.
Give him Narcan.
Call the cops.
Money, go home.
That's it. You're done. Now, maybe you don't see that. Maybe they're not breathing for 100 other reasons. Yes, I agree. It's not so easy.
Interesting fact about Narcan, that even if you give it to them and you were wrong, it doesn't have any bad effect as a result.
Okay, so there's no such thing as a drug without any side effects. However, Narcan is pretty benign and not that dangerous. But what I will tell you is something that they won't tell you in the literature. If you give somebody Narcan, okay, and you give them 4 milligrams, I've been using this stuff for 20 years. I have never given anybody more than about 0.8 of a milligram. Because here's what they don't tell you. If you wake them up and take them out of that heroin-induced frenzy, let's call it, they get extremely violent. They don't like that you just wasted all that money and brought them back. They were in a happy place. They get extremely violent, and very often they throw up extremely violently. They don't tell you that Narcan does that.
So why?
Okay, I use Narcan just enough to get them breathing. That's it. I do not wake them up.
So why are they giving it at four?
Because they don't understand. They've never. The people sitting in an office.
Preserving the
in,
highs since 1990.
The people sitting in an office in Albany deciding these things have never given Narcan to a real junkie and seen what happens.
They've never been behind the Home Depot.
Is that where it's at?
Yeah.
So me, I give it IV. I put it in IV, I let them wait,
That's why you don't get 4.
I give it slow increments
But aren't you
of
fighting against the clack?
No!
If he's in respiratory,
Plenty of time. I gotta be an EMT bagging them, or whatever, I do a different system altogether. No
Make the
problem.
empty blowing.
Rebbe, what would cause
Mouth to mouth.
someone to have a constriction? Besides this, like, could there be anything like could trauma theme? I know it's different.
Trauma will be unequal.
But is there anything else?
No.
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 Okay.
There's no contraindicated in Narcan.
Yeah, if they're breathing. If they're breathing, it's contraindicated.
What
Yeah.
happened to wobble?
It's completely unnecessary, and therefore contraindicated.
question.
Breathing or having a hard
what
time
is the
breathing?
problem that Narcan is fixing?
them breathe if they're already breathing?
Oh, what is the problem that it's fixing? Well, that I could do a whole 4-hour lecture on how the receptor cells that the opioid binds to, the Narcan will
No,
get in its
in
way.
English, in
Oh yeah,
20
I read
words
that
or
in the
less.
Mishpacha sometimes.
That's all I'm saying. I want to move
I
on.
know, but
I want to move on.
it
It replaces the receptor cells.
Hi, Eli.
that allow you to breathe.
Can't you use
So,
What's the two Narcan?
I miss you. It's 1091.
nitroglycerin.
Oh, fun.
Nitroglycerin, often shortened, just called nitro. This is the second and final drug that you do not carry. However, if the patient has his or her own and it belongs to them and they meet the criteria, you are able to assist them. Now, nitroglycerin comes in 2 ways. This, which is extremely expensive, this is what I carry. A lot of medic services provide these. Many do not. Most of them carry these. Now this, I want you to actually take a look at the size of these pills. They are minute, tiny little pills. But they are the strongest vasodilator known to us at this time. Nitro is extremely potent, and that tiny little pill put correctly under the patient's tongue will vasodilate their entire system.
What if I take
What
them
is
now?
the problem if we vasodilate too much? What could happen
Blood
to
will go out.
Hypovolemic shock.
Well, they won't go into hypovolemic shock. To go into
Distributed
hypovolemic
Blood
shock,
pressure, low blood pressure.
Distributive shock.
right? To go into hypovolemic shock, you've actually got to lose volume,
Low blood
right?
pressure, no?
Right. So they're not losing any volume. However, they may go into a form of distributive shock, where all the pipes, all the vessels get, right? And the blood pressure will drop. I have seen one of these tiny little pills drop a patient's blood pressure by over 60 points on their systolic level. 60 points. And that's huge. So,
Each dose is one.
yeah, each dose is one of those tiny pills. That's how potent it is. Okay? Now, there is a rule in New York State, and this will not say in your big fat textbook, because that is not a New York State book, but the rule is, for BLS at this time, if the patient's systolic blood pressure is less than 120, you may not assist the patient with their nitroglycerin. Let me repeat that. If the patient's systolic blood pressure is less than 120, you may not assist them with their nitroglycerin. You should already have medics on the way. So who's getting this medication and when can we use it? So it's for any patient who you gave the aspirin to. Let's put it that way. Who did you give aspirin to? A
MCI.
patient that you thought was having an MI, a chest pain, cardiac-related chest pain, and they happen to have this drug at home. They will not have the spray, I can assure you. They will have these little pills. Another thing you should know about the pills. The pills may have quite a long expiration date on the bottle. The problem is they are light sensitive. And if they've ever opened the bottle and they let sunlight in, or they kept it on the window ledge, and the sun was beating in on it, nitro always comes in a dark brown bottle for that reason, but it never works. And anything over 4 or 5 months, they lose their potency and they don't really work properly, okay? So, the patient has to have it, has to belong to them. They have to have chest pain, and you believe it's cardiac related. They also must have a systolic blood pressure of greater than 120.
Why would someone have this at home?
They were prescribed it
For what?
because they've had angina. They prescribed it for their angina. They have it at home. Okay? And their doctor told them PRN. If you need it, if you get the chest pain, you take one. You put it under your tongue, you take one, and if it doesn't go away, you call an ambulance.
But a regular person with chest pains, you wouldn't want to give this to. Like
You can give it to.
If they have it.
But this person is, because he has angina, so it's a problem if you know that he has a
You don't carry
That
that.
can, it's only if they have it.
It's only if they have it.
They would only have it.
so then they would only have it because they
Yeah,
have it.
they were prescribed it. Okay? Now, there's one contraindication other than the systolic blood pressure, and that is the Viagra. The Viagra, what we call
Next
ED,
question? I don't care.
yeah, ED medications. If your patient has taken any one of the ED medications, which means erectile dysfunction, within 72 hours, contraindicated to give Viagra, even to assist them with the Viagra.
Nitroglycerin.
Yeah. With the nitroglycerin. They've already taken that. Very good. With the nitroglycerin.
You can assist.
Okay.
Misty on the bus.
So this is the second medication. The first one was the metered dose inhaler that we spoke about at the beginning. This is the second one that the patient has. You don't have this. It's all in the chart. And
Not the epinephrine
epinephrine you carry.
that we have.
Okay? All right, the next two I want to do really quickly.
So the spray nitroglycerin goes in the mouth also?
Sublingual. Under the tongue. Here. Round. Sublingual. Under the tongue. Let me talk about the next two slides together. Okay? Because they have something in common. Syrup of ipecac and activated charcoal have been removed from all ambulances in New York City. Okay?
You're not solid?
Are they all ambulances? Are they in New York City?
They operate a very
yeah,
large
they have.
contingency, I'm telling you.
Okay.
Long Island?
So, all ambulances in New York City, these two drugs have been removed. They were certainly in protocol and on every ambulance when I became an EMT, and they have now been removed from New York City. You need to know what they are, but I'll tell you the most important thing you need to know is an answer to a test question. Ellie woke up. Here's the answer to test questions on Serpivipicac or activated charcoal. And the answer is
Contact.
online medical control for all doses and usage. Okay? So, yes, you have to call somebody, your online medical control, depending on who you work for, or where you work, or who you volunteer with, and they will tell you if you can use it. Let me just run through quickly what the drugs are, what they do. Serpivipicac is a drug known as an emetic. Emetic. It is a drug that makes you throw up. Today, as medics, we're doing just the opposite, and we're stopping anybody from throwing up in the back of ambulances. We're giving drugs for that. So we don't want anybody throwing up, okay?
Pain in the neck to clean up.
What drugs do you give to prevent it?
Doesn't matter, you don't carry it. You can't use it for now. Right? So, Serpivipicac, as it shows here in the picture, is even the rabbit is throwing up, everybody's throwing up, okay? So, that's all you need to know. It's an emetic, it's about this old, this is probably a pretty good picture of how old it is.
If I'm wearing a new suit, that's a contraindication to get it.
Maybe, but if you're in New York City, you won't be getting it anyway. Activated charcoal does something slightly different. This was interesting. With this, you had to get a cup of water, then you had to mix this powder in the back of a moving ambulance through Brooklyn streets, right? You're mixing this black, nasty powder into the cup. Now you got to get the patient to drink it in the back, facing backwards in a moving ambulance. Yeah, it was really, it wasn't good.
Charcoal absorbs the.
Activated charcoal is not an emetic. It absorbs the poisons from the GI tract. Basically, we go back to the famous thing that we've said a number of times. In New York City, you can go in any direction, 10 minutes, you'll be at a facility. You'll be at a hospital. So, to start doing this in the back of the ambulance makes absolutely no sense. They are still in New York State protocol. If you go after get your certificate, and you go and move to Rochester or Buffalo, or any of these places in the rest of the state,
Or Ithaca.
yeah, Ithaca, you will carry these drugs and you will contact medical control if someone gets a poisoning and you think that that would be appropriate.
These are over the counter. You can get these in CVS.
Correct.
This is
Are
good
they
for
giving
anorexic
this-
people.
EMTs at the contact medical.
This is good for anorexic people.
The
Do you want to
syrup.
read together?
The syrup.
Like
syrup.
Bulimic.
Very rarely, but this
Whatever,
is a
yeah,
case where
bulimic,
you would.
whatever.
Now, for someone that would have needed this, when they get to the hospital, would they be given?
They may, yeah. Yeah, they may. But there are better things today.
Oh.
Okay? All right, we spoke about the 6 rights of medication administration. Whenever you give somebody a medication, see, you won't be tested on this, you will. All right? You will not necessarily be tested on this, but it's very good for your general knowledge to know what these are, okay? So, just go down the list. The right time. Time, anything to do with time. Is the drug still within its date? Okay, you can never give a drug that it's expired. The right route. How are we supposed to give this drug? Okay? If it's the nitro pill, right? We shouldn't be trying to snort it up the nose with the atomizer for the Narcan, right? It goes sublingual. The right medication. Okay, is this the medication that it looks like? Okay? The right patient. Like I say, if the patient tells you, oh, I have my inhaler over there in the other room, bring it to me, and you get there and there's 4, right? And this one says Bob and Todd and Jim and Sally, bring the right one for your patient. The right dose. Okay? With the Narcan, you have to know half the vial in one nostril, half the vial in the other nostril. Very good. With the aspirin, you have to know 4 81 milligram aspirins for New York State. And the right documentation, make sure that you document everything that you gave and what you did. So,
Rabbi,
There was a question on the aspirin.